Okay, folks, good morning. I just wanted to start with this wonderful news from WHO and haven't heard from Fauci's mouth. I was going to call something else, but they want you to wear the masks. So Delta variant is coming, so it is just not in our offices and everywhere. They want us to wear the masks everywhere. Okay, so we want to talk about the LCD process and our participation and about epidural procedure policies mainly. We can touch base on some of the other policies too. So this is one of my favorite quotes. Ronald Reagan said, "I am from the government and I'm here to help." Those are the 9 most terrifying words in the English language, according to President Reagan. And that is actually true. Biden really wants to focus on more and more. He was saying yesterday, "I sent you $1.9 trillion. I'm sending you checks every week. Employers learn, pay more." What a secret. So no wonder we don't have, half the restaurants are closed, and the ones which are open, half open. We don't even have a gift shop here. They are asking us, do you want your room to be cleaned every day or not? There is no service available. They are doing a great job at this hotel, but still, they are struggling. So how did we get to participate in this? This is how it started. Several years ago, they were putting out the first epidural policy in Kentucky and Indiana at that time. So we wanted to talk to the medical director. He said, "You can't do anything unless you are on the CAC." So I asked him, "How do you get on the CAC?" I didn't know what a CAC was. He showed me that your state association has to nominate you, and we didn't have a state association at that time. But I went to the Kentucky Medical Society, and the president happened to know him, and he said, "Oh yeah, I will nominate you." So he nominated me. I replaced University of Kentucky professor Bill Witt. So I didn't realize that I was doing that, but that is what happened. That created a little bit animosity among us. After that, then I got this idea that we should have in every state our own representative for our own field. So we worked hard for several years, and finally CMS said, "No, we won't add it." They actually said that, well, if we add you, then somebody will come with a toe specialty, and somebody will come with a toenail specialty, so we can't have all these people. So Ed Whitfield actually introduced a legislation, and he called the CMS folks to his office, and we talked. And Dr. Sam Hassenbush was with us at one time on that issue. So after that, I went to Dr. Ann Northrup to talk about for her support. So she said, "Oh, Lax, I have a better idea for you here." So she asked me to come back, and I went back, and she added the language to appropriations bill. And here we got on it in 2005. And that is the year we got our NASPR Pass 2 in August, and in February we got a mandatory seat. And everybody was surprised. I was in India. I got a call from Wall Street Journal asking my opinion how we got on it. So what are we doing with IPM services? So that mandates that each state will have 2 representatives on the CAC, 1 primary representative, 1 other alternate. So how are our services doing? We are growing. Services are increasing, but if you take the rate per 100,000 Medicare population, they are down. There is a reversal of the services. We used to do a lot more epidurals in the beginning. Now we are doing a lot less, about 20% difference. But we are doing more of facet joint interventions. I did not include spinal cord stimulators in this, so I will show you in a second. The services are also moving somewhat since 2009, more to the ASCs and offices than hospitals, except for the folks who are employed by the hospitals. Medicare population is growing at a rate of 3.2% annually. Our services are going down at 0.8%, so we are not increasing. This includes epidurals and adhesive lysis also. Then if you compare all the services, epidurals and adhesive lysis have gone down 2.6%, facet joint interventions 0.9% annually, disc procedures and all types of other nerve blocks 1%, all interventional techniques 0.8%. Epidural and adhesive lysis, if you just look at the services, they went down 21%. Facet joints going up 8.1% total, and disc procedures 8.6%. Overall, we are down 6.7%. This is how the facet joints are going up. This is how epidurals and adhesive lysis procedures are coming down. If you just look at the percutaneous adhesive lysis procedures from 2009 to 2018, 69.2% decrease. This is a substantial decrease in utilization because of the non-coverage by Noridian and Palmetto. So you look at the overall picture, what is happening to our spinal cord stimulation and everything else. For epidurals, that was the highest spent in 2009. It was $847 million per year for fee-for-service Medicare population. But in 2018, it went down to $829 million. Facet joints were almost $600 million. They went up to $912 million. But spinal cord stimulation, they were $292 million, but they went up to $1,142 million. So there is significant difference in this. So we are all excited about everybody needs a spinal cord stimulation for back pain, toe pain, neck pain, every type of thing. So, and then we have peripheral nerve stimulators for everything either. I'm not saying we should not do that, but we have to be extremely careful what is happening. One of the requirements for them to look at the LCDs or issuing a NCD is explosive increases, which hurts the program. So if they think that this is going to hurt the program, then that is going to be a problem. So we applied for a change in the Century 21 Act. Is it Century 21? 21st century, okay. That is a realty company. 21st Century Act. We applied for a change. We gave them a 4-paragraph language, and one of the members of the Congress, he was so over-enthusiastic to support us, he took it on himself, removed the 3 paragraphs and kept the top paragraph. And now we ended up this multidisciplinary, and we lost all the protections we had in there. So LCD is a determination by Medicare Administrative Contractor, MAC. You went through this, Esther. They did a good job, I think. Whether a particular service or item is covered on a contractor-wide basis. So who can serve on the CAC? Anybody nominated by a state society. If you realize for interventional pain management, we are the only ones with state societies, and we are the only ones with a IPM definition too. Pain management has a different definition, anesthesia has a different definition, but anesthesia has their own reps actually. They tried to stop us getting the CAC membership, saying that you don't need that. We will appoint you to that, but they never did. So CAC members' role is to attend the CAC meetings and get the information, and also keep in touch with the members in the state. A lot of us are not doing that. So CAC members may be asked to serve as subject matter experts or identify such experts for specific LCD considerations within their own specialty. So I was involved significantly in preparing the facet joints, and not so much as facet joints, but pretty significantly in the epidurals also. So they have the CAC meetings, evidence distribution, summary of evidence, an explanation why they did everything, and it is easy to provide explanation. I can sit here and argue on both sides of the case like an attorney, so it is not that big a deal to do those things. If you want a new LCD request, you can submit that. We submitted for a new LCD, Amol and I, with CGS, and they got so excited. This is the first one in the nationwide. Nobody ever submitted for a new LCD for adhesive lysis and cervical epidural. Those were the two we had ready and applied. Then they never bring it for consideration. Medicare director and another one, we had meeting with three of the folks. They never brought it. Then epidural guidelines started coming. At that time, I asked them if they can just merge with them, and they agreed with it. Even though CGS was not the major force in this, Novitas, I talked to Leslie Stevens, and she said that was fine. And we included it. So how do they develop the evidence? Based on the clinical guidelines, consensus documents, by experts consultation. Actually, consensus documents should not have that high a value, but somehow they got in here, like Steve Cohen's guidelines. They are consensus guidelines for facet joints. They put them at the same level as ASIPP guidelines, which are evidence-based guidelines. Then there is a public comment period of 45 days. This causes a lot of problems. NGS folks didn't even know that it was released. I didn't know that epidural policy was released for 3 weeks until John Swicegood sent me a nasty email, not nasty to me, but nasty to the policy, saying that how bad it was. And NGS folks, they had an open meeting. They didn't even know that an hour before. And here is the proposed LCD. I can't find a date when the comment period is. So you guys can look at it. If you find a date, let me know. So this process is kind of getting out of hand. They give a final determination, public comments on facet joints. They really didn't make that many changes, but initially we got most of it what we wanted, so it was okay. If you don't like the LCD, you can go through a reconsideration process. Sometimes it works, like we did that on vertebral augmentation. They had pretty onerous things where we were actually, in our own practice, they were asking for refunds, so we were able to get that the way we wanted, but it took more than 1 year. So you can also challenge the LCD and evidentiary content. They have to show that reasonable and necessary provisions in LCD, like she was showing yesterday. The problems of LCDs is that it is just not the Medicare. First of all, it bothers every Medicare, and then Medicare Advantage or disadvantage plans is about 30%. They all follow the same thing. If it is not covered by Medicare, they're not going to cover it. All federal programs, the same thing happens. Medicaid, all Medicaid commercials, whenever it is necessary, they are going to use these policies. All commercial insurers are using it now. So this is where the multi-jurisdictional Contractor Advisory Committee meetings come, and that is the role of them to develop a national LCD essentially, but it is not NCD, but it is a national LCD. The same LCD will be propagated in each region for everyone. So they can have subject matter experts. They have not defined who can be the subject matter experts. On epidural, There was one guy, he hasn't done anything other than a transforaminal all his life. How can he be an expert on that? And he was talking about the evidence published in, even before I got into the field, like 78 or 76. Then we had two, Roger Chow and another one, they were all negative folks. So they already knew that. They give 0 for everything. 0 evidence, 0 evidence, 0 evidence. This is the pain group MCDs. This is the gang of 10. If you are interested in any one, if you know anyone, those are the ones. Vertebral augmentation, this was the first LCD they did. Actually, Josh Hirsch, they gave Josh the moderator's role here. And he was the moderator too. Instead of one of the CMDs, he moderated this. But we did very good in this. First time, everybody was enthusiastic, and we were able to gather 58 people get involved in voting. It keeps going down. The interest keeps going down, and people are only with negative opinions start showing up. Positive people start dropping out. The facet joints, so there were so many people in that, and facet joints, they just used only the experts. They didn't use the other CAC members' opinions. So we had the facet joints, and so they look at various issues there. Now comes the epidural policy. So we had that on February 11th, 2021. That was very stressful time for me. Here was the things they have removed. For discogenic pain, they had 3.43 on a scale of 1 to 5. So that is a very good evidence. Now they're not even going to cover it. Then spinal stenosis, of course, 3.9. It does not say with neurogenic claudication, but they won't cover it unless it is neurogenic claudication. Foraminal stenosis, they will cover that again if there is radiculopathy. So they didn't have that big evidence for acute herpes zoster. They won't cover the chronic post-herpetic neuralgia, but they will cover the acute herpes zoster. And they have to wait 4 weeks. How the hell is acute herpes zoster after 4 weeks? It's no longer acute. And it didn't even have a very high score on there. And what is your confidence interval to continue the treatments over 6 months? Very high score, 3.96. Now they are saying that we have to collaborate with the family practitioner, family physician if you want to continue beyond 1 year. And moderate sedation actually had 3.53, but not to use any moderate sedation. So all the ones who are complaining about moderate sedation, they say, when I told several people yesterday that you can use mild sedation, they keep saying, can I bill for moderate sedation? Come on, wake up, guys. So you can't. It is mild sedation. How can you bill for moderate sedation? That is the only thing allowed. And epidural adhesive lysis also got a score of 3.21 on a scale of 5. We also have demonstrated cost-utility analysis for all procedures. We are looking at actually better than spinal cord stimulation. Spinal cord stimulation is good too. But we have lumbar facet joint nerve blocks, percutaneous adhesive lysis, cervical facet joint nerve blocks, thoracic epidural, caudal epidural, and lumbar epidural. And the cost-utility was calculated exactly same methodology they used for disc herniation and spinal stenosis with fusion, which is $115,000 and $77,000 and $69,000. So we are much, much better cost utility when you look at it. So what are the issues with the proposed LCDs? One of the things we were talking about is improper notifications. Now, these are the 6 major issues in this is they deleted the percutaneous adhesive lysis from consideration. They deviate from existing LCD without evidentiary basis. They are using extremely rigid criteria, only radiculopathy, neurogenic claudication, and approved codes are inconsistent. They do have a code which says spinal stenosis without neurogenic claudication under covered codes, but under covered indications it is not there. It is inconsistent. Repeat procedures beyond 1 year is questionable. Restriction on multiple region treatments. Yesterday we had that discussion with them. So on percutaneous adhesive lysis, there is significant evidence with relevant moderate to high quality randomized trials. People are just jumping with one randomized controlled trial, they want it covered. Here we have multiple randomized controlled trials. We also have relevant moderate to high quality systematic reviews. And we also have guidelines on it. Confidence score was 3.21. Cost utility per year of improvement is 3,710 on a 2-year margin. We looked at 2-year cost utility, and this is based on exactly what they utilized for spinal stenosis surgery and disc herniation surgeries. We used the same methodology. So issues, existing core LCDs versus proposed, deletion of multiple covered conditions like degenerative disc disease is no longer there. Even disc herniation is not there. Discogenic pain without facet joint pain is no longer there. Spinal stenosis without radiculopathy not there. Number of procedures. Right now it is, if you go different states, in CGS you can do 2 procedures in a therapy initial phase with at an interval of 1 month or 3 weeks, something like that. So, whereas in other jurisdictions, I think most of the other jurisdictions, you can do 3 procedures in 6 months per region. So that means you can do 6 procedures per region per year. So they reduced them to a total of 4 procedures anytime in the beginning or at the end. And there is more to that. Then you can repeat the procedure only if you have more than 50% improvement for 3 months. So they removed the initial and therapeutic phases, and you cannot perform multiple procedures. Rigid criteria, radiculopathy and neurogenic claudication, herpes zoster, and deletion of the same things as I was talking about. Discogenic pain without facet joint pain score was 3.43. It's a pretty high score. No opportunity to treat the patients with epidural for CRPS or neuropathic pain. Repeat procedure, second procedure after 3 months with 50% relief, limit of 4, no initial and therapeutic phase, no evidentiary basis. So we looked at we did 13 randomized controlled trials in our own practice. We looked at all of them. How much relief do they get with the first procedure? 5.69 weeks on average. How much do they get second procedure? 10 weeks on average. So there is a range. It is 11.2, 10.2 plus or minus 12.57. That means somebody may even get 22 weeks of relief. And with the first one, they may get 13 weeks, but the percentage is lower there. That is the high. So these are all the studies we used to come up with the data. All the studies had 100 to 140 patients in each study. It did not include adhesive lysis. Adhesive lysis does get better relief with the first procedure because our selection criteria is that we choose that procedure after they fail epidural injections. Second procedure, 10.2 weeks. multiple treatments. The studies show that 60% of the patients have two-region involvement, whether you treat them or not. I see some of the doctors, they just do one epidural and do trigger points everywhere. I don't know how effective that is, how scientific that is, but that is what they do. They don't listen. And these are significantly restricted. Patient inconvenience, provider increased workload and costs, more expensive for the program itself, for all the programs. Any program which follows this regimen, instead of paying 150%, they are paying 200%. So if something is costing them $150, it will cost $200 now. The economics don't work out. The reason why they are doing is people get sick and they won't seek that treatment. That is where they save the money. So that is a major access issue. Again, more expensive, and unintended or intended consequences. These are not always unintended. They do want these things to happen, and that is what is happening. All Medicare Advantage plans with high copays and deductibles doubling the pain. Some of these Medicare disadvantage plans have, like in a surgery center, their copay is $295 or $300. Approved amount is only $287. And they come for another procedure, they have to pay the same amount of copay. These people can't afford. What Biden is saying is that doesn't work for the elderly. He didn't send any money to the elderly people. But elderly do like this because if they cut our 6%, their copay goes down. That is the advantage they show to the Democrats show to them. Here is a big Democrat there sitting, so he's shaking his head, but that is their marketing point. We reduced your copay. But they just don't understand that they also reduced the access. All government plans follow that, Medicaid, commercials, and overall it is a significant access reduction. Treatment beyond 1 year, you have to show appropriate medical necessity and also communicate with the family physician. Summary of issues, rigid criteria. This can reduce eligible population by 30% or to 30% actually, that is the wrong slide. To 30%. If you want to everybody have radiculopathy proven by EMG or reflex suppression or demonstrable motor weakness, it is going to be only 30% of the patients we are doing now will be eligible in the future. And then 50% improvement for 3 months, out of that 30%, 70% will be gone. So we are going to be left with 10% of the patients, we can treat them on a long-term basis. So adhesive lysis was already deleted in 2 jurisdictions, that is Noridian and Palmetto. If they don't include in this policy, this is going to be a very difficult issue in the future to perform this procedure anywhere. So overall, reduction in access, increasing costs, moving to expensive treatments, at least initially, all these facet fusions and peripheral nerve stimulators and central nerve, spinal cord stimulators, these are all going to be explosive because there is no other option to treat these patients. Increasing opioid utilization. We thought we have the opioid epidemic under control, even though they say it is not because of the illicit drugs. That can be a major issue. Increasing disability. People will have more disability and more drug abuse because we are not giving them enough opioids and we are also not treating them. So they seek assistance somewhere else. Then they die sometimes. So the deaths increase. So what are our next steps? You can do a local presentation. Some of them already is done. Novitas is done. NGS is done. CGS is coming. We are going to present. So Some of the others may have it. WPS may still have, Noridian may still have it. But Noridian is dominated by ISIS folks there, so it is very, little bit difficult to focus. They're married, so. Comment letters, we have to write a comment letter. We have to put our egos aside and sign on to one comment letter. You always have individual problems. I want to do 8 procedures in a year. That's not going to work. Go with something reasonable. I want to do adhesive lysis on every patient. That is not going to work. You have to do only when they meet the indications and medical necessity. So if we are reasonable and we are united, we can achieve something. If you keep breaking up, it is not going to do any good. Like we are still asking about the same issues over and over again. So on facet joints, probably we'll apply for a reconsideration, which will take almost a year to get it done. But our focus is going to be increasing the levels when you perform on one side to 3, and permitting the multiple procedures, which is also part of epidural policy. And we are going to do some federal lobbying with the CMS Coverage and Analysis Group. And we are wondering if we should get patient involvement, not a knee-jerk reaction, but that can also irritate the Medicare directors and can hurt, so we are just looking at it. Because if you bombard them with all these letters and phone calls, then they get irritated and they try to react in a different manner. So right now the consensus is limited to only the physician comments, or if not, state presidents and CAC members' commentary. And if we can get a unity on this, and all state societies and all CAC members sign on, and not send another stupid letter after signing on to this. There is no value for your word. You sign on to this letter and send another letter contradicting this. There is no value for such thing. And just remember, you're all working with ASIPP. The reason why you are on the CAC is ASIPP. The reason why you are state president or officer is ASIPP, not your personal ego, not your personal issues. So when we get a consensus, and we have to stick to that. I compromise too much sometimes. People tell me that I compromise too much. But in the beginning, I stand for everything, but when the time comes to compromise, you have to compromise. A person who cannot compromise cannot succeed. And if you cannot compromise, if you can't understand, person who can't pass their ignorance can't succeed either. So that is where we are going to move on. So I want to show you a couple of, this is the CGS hearing. So this is a complex process again. For every complex problem, there is an answer that is clear, simple, and wrong. Everybody thinks, oh, it is clear and simple. They just need to do that. But it turns out to be wrong. It is a complicated process. If we work together, if we focus on it, and remove me, myself, and I from the picture, 3 important people in my life, me, myself, and I, right? So just remove that for a while, and then we can succeed with it. So this is the letter I wrote to Dr. Meredith Lovelace, and this is what she responded in reference to the general anesthesia and MAC. General anesthesia, MAC, and moderate deep sedation are not allowed. Light sedation to relieve anxiety allowed, but should not be so deep as to alter patient's awareness. So you cannot bill for this. This is just a mild sedation. There was another letter, maybe not. Okay, again, same thing. Fear, it is our choice. Forget everything and run, or face everything and rise. I take the second option. Okay, thank you.